All right. These workshops are always a little bit strange because it means that I have to introduce myself. And introducing myself, it also means that I can correct the program a little bit because the program says that I'm from the United Kingdom, which is not quite true anymore. Yani hemşire oldum. 2,5 senedir buradayım. But I was in England before. That's where I trained in cognitive behavioral therapy. But if the program says that I was in the UK or that I still am in the UK, it gives me a good excuse to speak in English because my Turkish is so-so. It would not be enough to talk for 1.5 hours in Turkish, unfortunately. All right. So this is a workshop. It means that I would like to make it as interactive as possible. And so questions in between are welcome at any stage so that we can really make it as interactive as possible. Ideally, we would sit around a large table so we could be more interactive, but hopefully we will manage. All right, maybe let's start with evidence base. Is there an evidence base for cognitive behavioral therapy in somatization? And one of the biggest research papers to date is a work by Krönke, which is a meta-analysis looking at 34 randomized control trials involving nearly 4,000 patients. And in 13 studies, CBT was used. And 2/3 of the studies involved somatization disorder and lower threshold variance. That means it didn't fulfill all the criteria for somatization, such as abridged somatization and medically unexplained symptoms. CBT was effective in most studies, 11 out of 13, for mood, anxiety, and function. Okay, so we know cognitive behavioral therapy is effective in somatization. But now what? What do we do? Maybe it's useful to look at a patient. But maybe before we look at the patient, I can ask you, who of you applies cognitive behavioral therapy of some sort in daily practice? Okay, there are some of you. All right, great. Who of you sees people who are somatizing in practice? Also a few. Okay. So let me tell you about a patient I got to know, and that was actually still during my time in the United Kingdom. Let's call her Wanda. And she was 37 years old, and when she came to the appointment, she had a cast on her wrist saying, I've got carpal tunnel syndrome, and she said, I've got pain in all my joints, I've got irritable bowel syndrome, and also often I've got dizzy spells, and often I've got numbness on my left side. But the doctors don't seem to be able to find a reason, so they sent me here. Is that a presentation that might also be one of your patients? Maybe. All right. Interestingly enough, most of the doctors where Wanda presents, or similar patients present, whether they are from any area of medicine or psychiatrists or therapists, have this kind of reaction. Oh, I have to get away from this patient. And I guess if we talk about cognitive behavioral therapy, it might be useful for us to try to understand our reactions to a patient like that using a cognitive behavioral model. So maybe we can use what is called the maintenance model, or in Turkish I think it's called idame modeli. How do we as doctors respond to a somatizing patient, and what are our negative automatic thoughts? So one possibility is somatization, it's not a proper psychiatric illness. Another negative automatic thought might be, well, patients will not be able to show insight at all. Sort of a primitive mechanism, isn't it? And they will not improve. I don't know what to do. It's a misdiagnosis. Maybe I know what to do, but hey, in this kind of clinic, I don't have the right background, I don't have the right setup, so I can't really do what I otherwise would like to do. And of course, that will influence our emotions, maybe frustration, hopelessness, anxiety, and it will, I guess, also influence our behavior, saying, oh, I don't want to have these patients in treatment. And if we look at psychiatric polyclinics, I think it's quite striking that there are many people with somatic symptoms, but how many people in a psychiatric polyclinic actually receive proper treatment for somatization? Even in other branches of medicine, orthopedy, cardiodome, Kulak, Burn, Boas, and so on, somatization is very, very frequent. Somatic symptoms are very frequent. Each of us is faced with a choice to interpret their own somatic symptoms. For example, if I look at myself, the muscle tension in my back at the moment, is that because I have to give a presentation? Or is that because I had to get up early? Or is that because I had to sit in a flight that was really crowded? Or because I had to carry my suitcase and it kind of gave me a bad posture? Or maybe the change of climate from Istanbul to Antalya? We all have to make choices how we interpret somatic symptoms. And all of us quite happily agree that certain circumstances, like giving a presentation, being excited, being fearful, might cause in us certain bodily reactions. But if we are faced with a somatic or somatizing patient, we still often have that avoidance reaction. And I think one reason for this confusion is that actually, if we look at the names given to these patients and to the illness, it doesn't really help to have a clear head, a clear opinion of what to do. So it's called somatization, somatoform, psychogenic, Briquet syndrome, stress-related, non-organic, hysterical, medically unexplained illness, functional, dissociative. Any more names you would like to add to the list? How can we as therapists or as doctors be clear if there's this confusion of names? How can we have a clear idea of what to do with a patient if there's no clear concept? The classification in ICD or DSM-4 doesn't help much either. So actually for a long time, even the classification, even the naming of this illness or syndrome has been quite confusing. So maybe it's time that we try to get a clearer picture of somatization, kind of applying the principle, know your enemy. Maybe DSM-5, which is going to come out in not too far a distant future, might be able to help us. So the work group looking at somatization in DSM-5 says somatization disorder, hypochondriasis, and undifferentiated somatoform disorder and pain disorder share certain common features, namely somatic symptoms and cognitive distortions. The second point they make is, this is why the work group is proposing that these disorders should be grouped under a common rubric called somatic symptom disorder. So quite likely in DSM-5 there will be this new group, somatic symptom disorder. What will somatic symptom disorder involve? Complex somatic symptom disorder, simple somatic symptom disorder, and the main difference probably is going to be the duration of the symptoms, with complex symptom disorder requiring about 6 months of symptoms, whereas this is only 1 month. There might be illness anxiety disorder in the same rubric, functional neurological disorder, in other terms conversion disorder, psychological factors affecting medical conditions, and other specified somatic symptom disorders, and unspecified somatic symptom disorders. So this might be the new classification. And if we look at this complex somatic symptom disorder, there are certain criteria that are likely to apply. And they are still being reframed and reworded every now and then, so it's not quite clear how exactly the wording will be. But it seems that the first criteria is going to be that there are somatic symptoms. But it can be one, it can be two, it can be many. It doesn't matter. The second is that there are excessive thoughts, feelings, and behaviors related to these somatic symptoms or associated health concerns. And at least two of the following are required to meet this criterion of high level of health-related anxiety, disproportionate and persistent concerns about the medical seriousness of one's symptoms, and excessive time and energy devoted to these symptoms or health concerns. So we can see that in some way, this phrasing that there are cognitive distortions, the criterion that is placed here indicates that cognitive theory and cognitive therapy have somehow sneaked their way into the definition of this illness. There might be also possible specifiers regarding the clinical representation. One might be predominant somatic complaints, which would be what is previously called somatization disorder, predominant health anxiety, previously called hypochondriasis. But if the patient does have only minimal somatic symptoms, it might be called illness anxiety disorder. And predominant pain presentation, which previously would have been called pain disorder. But what are these cognitive distortions that this new definition is going to talk about? What are your ideas? Any ideas of what the cognitive distortions might be? You can even say it in Turkish if you want to. Maybe let's look at the example of pain. And if we talk about pain, I think it's useful to be aware that the neuronal circuits in the brain of emotions and pain overlap to a striking degree. Somatosensory cortex, prefrontal cortex, anterior cingulate cortex, nucleus accumbens, amygdala, cerebellum, hippocampus, thalamus, and insular cortex are all involved in some way in both emotional regulation and in pain perception. And among these important neuronal circuits that are involved in emotions and in pain perception, the insular and the cingulate cortex are areas of the brain that represent our perception of touch and position and pain temperature, and take a very striking key position in those circuits. So they process the stimulus in the context of other simultaneous perceptions like sight, smell, taste, hearing, and balance, but also in the context of memories and the present emotional state. And it's noteworthy that the peripheral pain and temperature information is channeled directly to the insula and the cingulate cortex without prior processing. So there's a direct connection. And this is different from the way that, for example, information for touch and position is processed. Of course, you have heard about the gate control theory of pain perception, where in the periaqueductal gray opiates inhibit certain neurons. This influences the rougher nucleus, which might then also influence neurons, and they might block the pain perception on the level of the dorsal roots. So pain, I think, is quite a good example of how top-down influences influence pain perception. And these cognitive processes involve expectation, distraction, and evaluation of the stimulus, and that changes the perception of pain. All right. So maybe it's useful to look at a quite interesting study which is about pain, perceived rejection, and relationships. Yeah? There's a study from 2004 by Eisenberger and Lieberman which examined the question of why rejection hurts. And they postulate and examine the link of the pain network and the rejection emotional network. And they say there's a common neural alarm system for physical and for social pain. So the authors present evidence that both social pain, for example, perceived rejection by other people, and physical pain are processed anatomically in functionally overlapping systems with the dorsal and rostral anterior cingulate cortex at the center. And they say there's a further component which might be a sort of discrepancy detection function, also centered around the cingulate cortex, which is activated when there's a discrepancy between the current state and the desired state. And according to the authors, this suggests that endogenous and exogenous factors that enhance sensitivity to one type of pain should also enhance the sensitivity of this alarm system and thus potentiate the sensitivity to other type of pain as well. So that means if someone has a negative emotion because he feels rejected, it will also mean that it will influence the pain threshold, for example. And there are actually quite a few studies that confirm this hypothesis. There are some studies from animals, and there are some studies from human beings as well. So one study from animals is, for example, that if rats are taught new behavior via punishment with electroshocks, they learn faster if they are on their own. That means they have no social component, than when they are in a group where there's social interaction. From humans, the presence of social support increases tolerance of electric shock stimulation and decreases levels of self-reported pain during a cold pressure task. Touching something very cold can be better coped with if there's social interaction. Individuals that are rejection sensitive compared to people who are not rejection sensitive report more distress when they are watching video clips of people experiencing physical pain. Again, it seems that these overlapping networks influence each other. The second pain modulator is attention. Of course, you know that a good example for that is if you have a child and your child falls down, maybe riding the bike or something like that, and the child hurts its knee, what do? You try to distract the attention in some way, and the child, hopefully, will not feel the pain as much and stop crying. But does it mean that something has changed at the knee? No, the knee still receives pain impulses, but the pain perception will change. But of course, talking about child and mother is one thing. Having nice neuroimaging images is a different matter. So here a nice neuroimaging study from 2009. And it was done in the way that people were asked to touch something very hot to trigger some pain. Half of the participants were asked to, at the same time, focus on a pleasant smell. The other half of the group was asked not to focus on any smell. Yeah? And you can see that people that were focusing just on the pain had a higher activation level in the brain compared to the people who at the same time were asked to focus on the pleasant smell. So attention, the way we direct attention, changes the level of activation in our pain networks. What about mood? Another neuroimaging study. In here you see various components of the network involved in pain perception, anterior cingulate cortex, thalamus, somatosensory cortex on these sides. And here the mood was changed by a mood induction technique by administering a bad smell. So the hypothesis is if you give people something bad to smell, their mood will decrease, and it should lead to an activation in the level of pain perception. And that seems to be the case. So here people were focused, or were asked to focus on a bad smell, inducing bad mood, and there's more pain activation in these centers than when were people asked to focus on a pleasant smell, where nearly no activation of the pain network seems to be present. But there are also some more lifelike studies where people after mood induction who suffered from chronic back pain were asked to perform some functional tests carrying a weight, and people who had induced good mood were able to carry the weight for longer and complained less of pain. So this brain activation and the activation level of the pain network also translates into everyday tasks like carrying physical activity even if you suffer from chronic pain. And the next pain modulator is expectation and meaning. And there's a study with a functional MRI on the neuronal mechanisms of hyperalgesic nocebo effects. Nocebo being the opposite of a placebo. All right. Okay. So people were given an injection with saline solution, and half of the group was told that the saline solution is actually not saline solution, but is a medication that will make them more sensitive to pain. So the nocebo effect was that people were told, with this injection you will feel pain more acutely at a higher level. And then they were asked to touch something hot, and the responses in the brain were compared between the two groups. And the people who were told, well, this medication made you more sensitive to pain, had a greater activation of the pain network. So there was a nocebo effect. Just the expectation of I will feel more pain actually meant there's a higher activation in the pain network. Which also indicates that thinking styles, which you of course are familiar with from cognitive behavior therapy, will have an influence of how the brain network, the pain network in the brain, is activated. And thinking styles that might influence the meaning taken from a pain experience are, for example, overestimation of risk. Something that is possible is estimated to be probable. If I have pain, it's possible that it is cancer, but the thinking style would mean that the patient starts thinking, oh, because it can be cancer, it must mean that it is cancer. All or nothing thinking. If I still feel pain now, it must mean it will never get better. Catastrophization. This must be due to a very dangerous illness. It will only get worse. This is just testing the effects of distraction on your attention to my talk. Thank you. Generalization. If I cannot do even this at the moment, I cannot do anything at all. Blaming. I should be able to do this for myself. I'm a burden to other people. A mental filter for negative information, and we'll look at an example later on. I heard from my neighbor that her aunt had the same and it was cancer. Other disconfirming information is not considered. So if we talk about pain, which is a very common symptom in somatization, we can say there's good evidence that pain perception is not only influenced by the stimulus from outside. The stimulus is one part of the pain perception, but actually other factors play a role as well. We talked about expectation, which is defined by prior experience, family learning, culture, mood and emotion, mental health, current stresses, relationships, socioeconomic status, context of pain. And also by how the person uses attention, whether he focuses on the pain or not, and how the person employs expectation, attention, and mood will also be influenced by the meaning that is given to the pain experience. For example, the pain giving birth might be experienced very differently because there's a different, usually more positive meaning attached to it, to the pain that is perceived during treatment for cancer, for example, where the meaning is very different. So my main point talking about pain as a very common symptom of somatization is psychological phenomena such as expectation, mood, attention, and meaning influence the pain perception, and they do so by causing changes in the activation of neuronal pain networks. All right, but now let's go, after this slight excursion, let's go to Wanda. What do we do with her? Wanda is coming to the appointment, and now she sits before you, and what are you going to do? All right, so we know that cognitive behavioral therapy is effective, and we know it can be conducted as in or as outpatient. It's possible also in group format, and at some stage it might be useful to involve relevant others, like, for example, the partner or the family, as they influence illness behavior. I think as a therapist or as the treating psychiatrist, it's very important to consider that it will take time to treat. The changes will not occur very quickly, and it's important for us as therapists to be aware of that, and maybe also for the patient to be aware of that. Because usually, how much time goes by until a person with somatization comes to see a psychotherapist or psychiatrist? Usually it's after years, because most commonly they have been to any other branches of medicine before they come to see someone for psychological help. If we talk about treatment planning, it might be useful to have in mind a certain structure. And I'll take you through this suggestion of treatment structure. So in the first 3 sessions, one big component should be the assessment and the conceptualization and also goal setting for the overall treatment. For about the first 4 sessions, it should also involve familiarizing the patient with a way of working. For example, that there will be homework, that there's a certain session structure, that there's a certain cooperative style in working together. And then, starting from around the second session, there should also be exercises, discussions, setting of homeworks that are aiming at treating the symptoms. At a later stage, it can also be about talking about core beliefs that seem to contribute to the problem. And the last 4 sessions should also be reserved to think about relapse prevention. What will happen after the treatment ends? How will the patient be able to take what he has learned from the treatment into the future to stay well? But as we said, the first step is the assessment. What are the biggest goals for the assessment? If you see Wanda for the first time, what would you really like to know about her in order to plan treatment? In my opinion, it's opening the door to a therapeutic relationship, exploring the patient's illness belief, and provide a rationale for treatment and instill hope. Because the patient, as I mentioned, usually has been to many other doctors, nothing has worked really, and they're usually quite highly frustrated about their symptoms. So somehow, if you want to start working psychologically, you have to manage to open the door to a therapeutic relationship and provide a rationale for psychological treatment. Of course, part of the assessment is also to look for psychiatric comorbidities, to look for other previous or current medically unexplained symptoms. And that is often quite a challenge, because one of the frustrating things about these patients is they have been to many doctors, which means if you want to get the reports and the opinions of the other doctors, it can be quite a lot of work. As you know, it's not so easy to access old notes from other doctors very often, unfortunately. You can look for past traumas, look for learning experiences. Has the patient witnessed similar physical symptoms in others? Has there been some modeling? Has the patient had a friend who has multiple sclerosis or a stroke, for example? And has the way that the person with the illness dealt with the illness influenced the illness? Looking for maintaining factors in the patient and family, and meaning and prediction about the symptoms. What does the patient think is the prognosis? What is the impact on life? Changes in activity because of the symptoms. What do you do more of? What do you do less of? Socializing, hobbies, sport. Has there been any change in how much time the patient spends on these activities? Intimate relationships in home life and work. And how generally does the patient spend their day? And how does he evaluate the effects of activity? Is there a sort of catastrophization and avoidance about activity? Or is there sort of the thought, I have to force myself to do everything when I'm good? Kind of meaning that there might be the risk of overactivity on good days. One area that's also useful to ask about is the presence of intrusive images. There's a study about health anxiety from 2010 by Muse and colleagues, and they found that over 78% of participants reported experiencing recurrent, distressing, intrusive images, and the images tended to be future-orientated, and usually had one of the following themes: I'm being told the bad news that I have a serious life-threatening illness, seeing themselves suffering from a serious or life-threatening illness, seeing themselves dying or having died from that illness, and the impact of their own death or the serious illness on loved ones, for example, the children. And the participants reported that they respond to these intrusive images by engaging in avoidance, checking, reassurance seeking, distraction, and rumination. So it seems that, as we said in somatization, anxiety about the symptoms plays a role. Intrusive images with frightening content also play a role in the conceptualization. So let me suggest a model about somatization to you that is built on several models I've come across, and I try to mix it to my own taste so that I think it can be a helpful guide for therapy. So for some of the patients, there can be a trauma, a traumatic experience in the past. As you know, in conversion disorder, especially in non-epileptic functional attacks, there's a higher incidence of past trauma, traumatic experiences. But in other areas of somatization, in other areas of conversion disorder, that is not the case. So it can be, for some patients, that there's a traumatic experience in the past. For some patients, there's also current life stresses. But these have to be seen against the background of how the person processes information, how the person processes emotions and somatic symptoms. This might be biologically influenced. For somatization, there seems to be a genetic risk. There might be impaired emotional processing, learning experiences stemming from the culture, from family, from peers might influence this processing, and dysfunctional ways to express and cope with strong emotion might also play a role. And this can lead to somatic symptoms, which again will be processed according to these rules, and it can lead to comorbid psychiatric disorders. As you know, there's a high comorbidity rate. They will all influence each other, and they will lead to iatrogenic factors, to the illness belief and the meaning given to the symptoms. They will influence the coping strategies the patient tries, and it will also influence the reactions from others, culture, family, and peers. If we think of our patient, of Wanda again, how might a conceptualization like that look for her? So for her, she was one of those who had a traumatic experience. Her father was alcoholic, and there was physical violence from her previous husband. She was currently unemployed. Because of her symptoms, she had moved back with her mother, so where she lived with her children and the mother, it was quite crowded, and there were financial difficulties. Biological factors, we cannot be quite sure. There was no family history, but it seemed that she indeed had impaired emotional processing, and what she had learned from her experiences was be quiet or otherwise there will be more trouble. Thinking of the alcoholic father and the violent husband, well, if I talk about my problems, that's not good. It just causes more problems. And her way of dealing with emotions was trying to be quiet, carrying on whatever the circumstances, and trying not to feel any strong emotion at all. As we said, her somatic symptoms was pain, dizzy spells, numbness and irritable bowel syndrome, and she also had depressive symptoms. Her reaction to all this was that she had many tests from many different doctors, many prescriptions, and she had received many mixed messages. We'll talk about the mixed messages and the role in somatization a little bit later. Her illness belief was this must be organic, there must be some sort of nerve damage that's developing in me. Her way of trying to cope with it, push yourself until you crash down. And her mother was part of the system, supporting her in a way, reinforcing the sick role, and she was accepted among her friends as being physically ill. All right, we said that one of the biggest points, the biggest functions of an assessment is to opening the door to a therapeutic relationship. And that's not so easy, because patients might be suspicious about seeing a psychiatrist or a therapist saying, "Oh, so you want to tell me it's all in my mind." And that's why it's quite important that we explicitly convey the belief in the reality of the symptoms and the reality of suffering. So confronting the patient saying, "Oh, look, all your tests were negative, so it must be something psychological," in the first session is not very helpful. So confrontation will not allow you to build that therapeutic relationship. So the best way forward seems to be non-judgmental in accepting the patient's point of view and avoiding discussions whether the problem is physical or psychological, but promoting a model of how emotions, cognitions, physical symptoms and behavior are all interlinked. So one technique to do that is called gentle questioning. And possible approaches might be, having these symptoms would be tough for everyone. do these symptoms ever get you down or make you feel frustrated? So you normalize that physical symptoms are a very distressing experience, and that might help you to get the patient to talk about emotions. What do they stop you from doing? How has your daily activity changed since the symptoms began? And normalizing, point out that how people feel influences how they can cope and recover from all sorts of illnesses. For example, recovering from surgery, and I'll talk a little bit about that point later on. So after the assessment, you should have all the necessary information to make a conceptualization that allows you to choose treatment targets. For example, the patient's illness belief. So we're talking about this point down there. And maybe before we talk about somatization and about this patient in particular, let's consider some general remarks about anxiety done by one of the professors at the Institute of Psychiatry in London, Paul Salkowski's. People suffer from anxiety because they think of situations as more dangerous than they really are. And treatment helps the person to consider an alternative, less threatening explanation of their problem. But if the alternative explanation is to be helpful, it has to fit with the patient's past experience. And it has to work when the patient tests this new alternative explanation out. And good therapy, according to Paul Salkowski's, means that it's about two or more people working together to find out how the world really works. So if we present an alternative or explore with the patient an alternative together, it should be a formulation as an alternative, less threatening account of the person's problem, and helping the patient to understand how the alternative helping the person understand how the alternative explanation works by formulating the alternative model, discuss it openly and cooperatively, and testing it. For example, with behavioral experiments, information gathering, and discovering thinking biases. I think this might also be sometimes helpful to discuss with the patient, that the level of fear or distress, if we use a more general word, depends on how terrible the outcome is estimated to be by the patient, multiplied by how likely the patient thinks this is going to be, divided by how well could I cope if it really happened. So for Wanda, for example, she says, if I really have a nerve damage, this would be so horrible, it would mean there's nothing left in my life. How likely? She said, well, I have symptoms now, so it must be quite likely. Which means, according to this formulation, the distress she experiences is really quite high about it. And because she says, I really think I wouldn't be able to cope with it, the distress keeps remaining high. So we said it's really necessary for any anxiety disorder, but also for somatization, to come up with an alternative explanation for the patient's experience. But at the moment, what often is the situation, like it's written here, so that you get the translation, I'll read it out. The doctor says, you have got somatoform, hysterical, functional, non-organic, stress-related, dissociative somatization. And the patient says, oh, can you give me a diagnosis that actually makes sense? So the hypothesis for somatization disorder is that the behavioral and emotional reaction, as well as the prognosis, is influenced by the patient's illness belief. The patient's illness beliefs are likely to continue as long as they are not presented with an alternative model that really makes sense of what they are experiencing at the moment. And starting from the assessment and continuing throughout therapy, this alternative model should be cooperatively developed and reinforced. But even if we develop this model, I think we have to be quite clear that the patient will sort of believe this new model, not continuously more and more, but it may go up and down, undulating. Sometimes he believes it, sometimes he doubts it, sometimes he believes it. So it will always be our task to design the therapy in a way that this new belief in this alternative model becomes stronger. So providing alternative illness belief starts with finding an acceptable name. We have seen that there are a lot of different names floating around. According to one study from Stone in 2002, it seems that functional seems to be quite an appropriate term and that it's more acceptable to most patients. How can we convey in therapy this concept of functional? So useful metaphors might be that, like in a machine, all the wiring is intact, but somehow the signals are not transmitted in the right order. Or for people who use the computer, that all the hardware about the computer is intact, but somehow the software crashed and needs some resetting. For people who like cars, that engine and all parts are intact, but the electronic of the car crashed and needs to be retrained, rewired. But of course you will say not every patient comes from a socioeconomic background where they use computers or where they have cars. Then you will have to find a metaphor that works for them. And if it's someone who has chicken, then you can talk about chicken. If it's someone who has dogs, talk about dogs. Yeah? For example, chicken is healthy and can lay eggs, but because the fox comes every night and disturbs the chicken, they are stressed, and that's why they don't produce eggs. Yeah? And you can say it's a similar reaction for you. There are so many things going on that it actually affects of how your body works, even though the body in itself is intact. Yeah? The word functional also seems to be able to convey the message that it can be retrained. So if it's a functional problem, this function can be retrained, which means with practice and exercises it can get better. And the point of comparing it to well-known physical illnesses can be helpful. For example, healing after surgery or healing after there really has been a stroke. You can point out that MRI findings and the level of disability after stroke, for example, don't correlate. Or you can start a discussion of which factors and behaviors result in better recovery, for example, after surgery, reinforcing the idea that behavior affects physiology. For example, you can start something, let us imagine there are two patients after surgery. One of the patients says, well, now that I had the surgery, I can't really do the activities that I wanted to do. I can't play football anymore. I can't have fun. I can't go out. So what's the point of going to the physical exercise? People, the doctors told me I can get up, but if I get up, maybe I will make it worse. So I'd rather stay in bed. And people who visit me, I really don't want to see them because in this state, I don't want to be seen by anyone. The other patient says, well, this is a challenge. It's really painful, and I really wished it didn't happen, but somehow I want to get better, so I do the exercise, and I really find it quite helpful when friends visit because it keeps my mind on other things rather than my surgery. And you can discuss with the patient, who do you think will recover faster? So talking about other people might then help the patient to discover that behavior and reactions to the illness might influence actually how well we heal. At some stage, it's also quite likely that the discussion will turn to stress. You can present an image like that, which might be introducing a bit of humor in the sessions. Depending on the level of education of the patient, it might also be useful to give some psychoeducation about what actually happens in the body and in the brain when there's a stress response. Depending on the level of education of the patient, you can go into details even. And usually there's some talk about the HPA axis and how cortisol is produced. In somatization, it seems that early life stresses may result in acute and chronic changes in the activity and regulation of the brain's biological stress response that creates a vulnerability in later life. It seems that for some patients at least, there's an initial hypercortisolism during the acute stress, which may then at a later stage be hypercortisolism. So initially cortisol too high and then too low. And there may be changes in free cortisol, in cortisol receptor sensitivity, in the synthesis of ACTH, and so on. So we know that stress on some level has a part to play in this disorder. This also points then the question to how useful is it to integrate relaxation techniques of some sort. Relaxation training on its own doesn't seem to be overly effective. There's a study by Deal in 1997 on chronic fatigue syndrome, and just relaxation exercises don't seem to be useful. But I think if you introduce it into therapy, it can be useful as a component of therapy in different ways. So it can promote that the patient learns that he has some control over how he feels. He learns about the body-mind connection. If I do certain exercises, it influences my body's responses. And if the person practices it often enough, it should also help to balance the HPA axis in some way. And it can also be a quite good way of starting together because it's a quite comfortable way of starting together. So it can be a non-threatening entry into working with psychological therapies. I think important is that the patient learns the relaxation technique as a sort of homework. It should not be constantly therapist-guided because we want to promote self-efficacy in the patient. So he should learn the relaxation techniques, whether it's mindfulness, whether it is meditation, whether it is guided imagery or self-hypnosis. It should be something the patient can conduct with some training under his own control. I think that's an important point. So relaxation can be a part of providing education about the mind-body connection. Discussion, as we mentioned, of psychological factors influencing healing can be helpful. Effects of distraction on the pain, this mother and comforting child example might be useful. And also behavioral experiments, creating experiences by guided focusing. What do I mean by guided focusing? For example, asking the patient to focus their attention on their left hand, closing their eyes, suggesting that maybe with some time they will notice some changes in that hand. Maybe they will become aware that that hand starts to have some tingling, or that it feels colder or warmer, or just a little bit different from the other hand. And usually the patient, like we all do, responds, if you continue to focus his attention on the hand, with experiencing some changes in sensation. Kind of allowing the patient to find out, if I change my attention, and if I guide my attention a different way, I really can have different body experiences. A useful method is also the theory A, theory B method at the stage of conceptualization. Creating with the patient a list of theory A and theory B. Theory A would be, my problem is I have the illness which damages my body and I can do nothing about it. And then to list together with the patient what really is the evidence for it. For example, yes, my aunt had something similar and it was a nerve damage. Evidence 2, this doesn't seem to get better. I've had lots of different treatments, and so on. To really explore with the patient what he thinks is a good evidence for this theory. And then developing the theory that's an alternative to it. I have true symptoms, but they are not due to physical damage. They're influenced by many factors, and many of those factors I can actually change or influence in some way. For example, people, I've been to many doctors and they told me they cannot find something organic about this problem. Actually, when I do go out and see my friends afterwards, I seem to feel a little bit better. I have heard from other people that when they feel stressed, they have similar symptoms, kind of listing the evidence that more supports this theory. And then discuss the different necessary action. Here, going to more and more doctors. On this side, maybe learning about some new ways. If we talk about dysfunctional ways to express and cope with strong emotions, iatrogenic factors, illness beliefs, and coping strategies, a useful way to formulate this might be using what is called the vicious flower formulation, Kötü-çiçek. Questions to ask to develop that conceptualization might be: when you notice your fingers tingling, what seemed to you at the time was the worst thing this could mean? And when you thought this tingling meant my body's breaking down, it will only get worse, how did that affect you? How did it make you feel? What did you do? What did you pay attention to? And how did you try to deal with it? And then to develop something like this. Tingling and numbness. The thought comes, my body is breaking down, it will only get worse. And explore the behavioral, emotional responses with a person. Seeking reassurance from my mother. Feeling weak and ill. Holding out my hand to really, is it getting worse? Is it getting better? What is it doing? Can I still hold? Ruminating about the consequences. For example, this must mean I have nerve damage. This must mean I will end up in a wheelchair. It must mean that I cannot have the life that I want. Checking for body symptoms. If there's some tingling there, what about my feet? What about the other hand? Is there some tingling as well? Being demoralized and depressed, terrified, attention to health information, for example, going on to the internet, Googling nerve damage. And then exploring steps for step with the patient, what are the effects of these reactions? Are they actually helpful? How do they influence the symptom, and how do they influence this belief? One important point is that when people have somatization, they usually visit a lot of different doctors, and they get a lot of different messages. And because they have some mental filter in their thinking, they will usually focus on the most negative aspects. But to some extent, it's also the fault of doctors giving mixed messages and not making clear statements. And in somatization or conversion disorder, a lot of different people are involved. Psychiatrists, the patient, psychotherapist, specialists, family and friends, nurses, physiotherapists, family doctor, and they all give some sort of message. Googleitis is also a contributor to it. So people might then go on the internet and read about different symptoms and really get worried. So it's useful to explore with the patient which mixed messages have they received from doctors, therapists, nurses, family, and media. And as you know, sometimes whatever the doctor says is not as effective as what the secretary outside says that just spends a little bit more time with the patient. So the secretary's opinion might actually be more believable to the patient than what the doctor said in the consulting room. Start decreasing mixed messages, exploring the effect. For example, a behavioral experiment. Google for 1 hour about all the different reasons for nerve damage and notice how that makes your symptoms. Does it increase the symptoms? Does it decrease the symptoms? How do you feel emotionally? Exploring decreased messages, internet search, doctor shopping, conversations with other people focused on medical topics. What are the effects? And then, if that has been done, to agree with the patient that there should be a limit to contacts with other doctors, decrease the mixed messages, for example, by also talking about, increase in anxiety, The cost, often it's important also to go to so many doctors. If someone says, oh, I've got financial problems, but I go to many different doctors to hear different opinions, it will only increase the problem. And also talk about possible unnecessary or risky investigations and treatments. There's a test for some patients, it might be useful to go through it, is imagine a disease that affects 1 in 1,000 people. And you take a test to see if you have the illness. And the test is designed in a certain way. No test is perfect. In people who have the illness, it always shows a positive, correct result. In people who do not have the illness, it shows in 95% the correct negative result, but in 5% a false positive result. Which means saying the person has the illness, although he does not have it. So you get back your result and it is positive. What is your risk of actually having the illness? Who knows? Make your mental solution. So actually your chance, even if you get back a positive result, is only 2%. Yeah? 1,000 tests, one person has the illness, and in that person the test shows the correct result. 999 people do not have the illness, but false positive is 5%, so 50 people get a false positive result, which means that altogether 51 people have a positive test, but only one person has a correct positive test. And 50 people have a false positive test, so your chance is only 2%. And to discuss that if they take a lot of different tests, how that will mean that just by the statistical reality, they will also always have some tests that show a positive result, which doesn't need to mean that they actually have an illness. Explore the effects of reassurance. Exploring and normalizing that it's normal that we ask other people for reassurance, but what are the patterns and what is actually the effect? Maybe to do a behavioral experiment. Give reassurance for 10 minutes. You're not ill, you're not ill, you're not ill. It means you're not ill, you're really not ill. It doesn't mean anything. You're well, it will be fine. And to explore, okay, how did that make you feel? Did it make you feel better? If yes, for how long did it last? Or to make a thought experiment. If we meet for 24 hours and I gave you reassurance, full 24 hours at an extra price, what would be the effect? Would you feel better? Would it solve your problems? Why not? Talking about attention, the metaphor of the torch, the Elfenry, I think is quite useful to say, okay, how does our attention work? And to make it more memorable, you can even give the patient a torch, ask him to go to a dark room and say, okay, just in the dark room, use your torch. What can you notice? How does it work? Are you able to illuminate the whole room using a torch? If our attention is like a torch, it also means we can choose what part of the room we illuminate. We can focus on the bad things, on the ugly things, on the good things, on the neutral things. It's our choice. Yeah? Behavioral experiment, as I mentioned before, directing their attention, for example, on the hand, and find out that when you focus your attention on something, you suddenly notice it more. If I ask you to focus on how your bum feels on the seat at the moment, how your trousers feel, how your shoes feel, just by focusing your attention, you will notice it in a different way. Maybe that is a little remark, and that is also the basis why there's some rationale to use something that is called attentional training in these patients, where people in a structured process learn to shift their attention or to focus their attention on different acoustic stimuli, which in theory should help them to be able to better maintain focus on non-threatening stimuli. It's used most of all in social anxiety, but it finds its way into other areas as well. Exploring mental distortions, and an example could be given like that you make little notes of all the negative statements the patient makes. For example, I feel dizzy. Uncle John died of stroke. I lost some weight. I get headaches. I get out of breath. I have a fast heart rate. And 10 years ago, I was fitter. It's all evidence for being at a risk of a stroke, right? But what if we introduce the other information as well? Uncle John was old and a chain smoker. I'm young and don't smoke. I feel dizzy when I worry about having a stroke. I actually walk faster and longer than many others. I have a fast heart rate when I worry or when I exercise. Many people get headaches. It's a non-specific symptom of stroke. I wanted to lose some weight because I wanted to reduce my risk of a stroke. And 10 years ago, I was fitter, but I also ran 3 nights at a running club. Yeah? So this might be a quite good method to introduce, that actually the patient might engage in something like mental filtering, and that it's useful to make himself explore the neutral information and the positive information. Catastrophization. Exploring intrusive images, as we said, and automatic thoughts. Are they realistic? Are there other explanations? Keeping a logbook and a challenging sheet. Exploring the pros and cons. What is the worst that can happen? What's the best? What is the most likely outcome? What strategies do they use in response to what effect? Attempt to control or avoid. In recognition of rigid rules, for example, I have to be perfect. To notice when they are used, discuss advantages, disadvantages, where do they come from? This might then lead to a discussion about core beliefs. And how would less rigid rules look like? What would the effects be? Let's try them out. In somatizing disorders, activity is quite an important part. Cognitions about activity that I think are useful to encourage in therapy are, first of all, to explore and challenge fears about exercise. For a lot of people who have somatizing symptoms, they will have cognitions like, if I do activity, it will make me feel bad or even more tired. It will damage me further. Cognitions to encourage might be, it's something I can do to help myself. I can accept some discomfort and fatigue because it's part of the training. My body can get used again to being active, kind of using this metaphor of retraining. And helping the patient to be realistic that minor lapses, some bad days, are part of getting better and are not a catastrophe. A structure for activity that might be useful is coordinating with a physiotherapist or the partner or the family, whoever is close to the patient, and negotiate weekly targets. And it should be structured and planned, and it should be really clear what kind of activity the patient is doing at what time for how long. And for people who have chronic fatigue syndrome, for example, initially it might be 6 single minutes of activity during the day, which then stepwise is increased to 6 times 2 minutes, 6 times 3 minutes, and so on. What is not so clear is what type of exercise is more useful. Is it more useful to have aerobic, anaerobic, strength exercise, stretching? That is still under discussion. It seems a combination would be the ideal in the end. And to explore the importance of balanced activities, a lot of people with somatic complaints might say, on good days I try to do everything. I clean the house and I go shopping and I run with my kids and then I play with my kids. And the effect is that the next day, then they will have more somatic complaints. Whereas on other days where they feel bad, they might say, I can't do anything, which actually makes them focus on the symptoms and increases the symptoms. Introduction of rewarding activity. Exploring changes in social activity and rewarding activity and activities that carry value. And by carrying value, I mean something like, for Wanda, for example, it was important for her to be a good mother. But she said, if I'm in pain, I can't be a good mother. So then it's a discussion about, okay, so even if you feel pain, what kind of things can you still do that a good mother does? oh, if I feel pain, I can still go through the homework with my children. Yeah? So to give some rewarding activity and to combat this decrease in positive activity. And also here it's useful to schedule, to make a weekly schedule of on what day will you solve, for example, the payments that you have to make. On which day will you go to the bank? On which day will you socialize? On which day will you go out with your kids? To really make a structure to it. Because it should become independent of the somatic complaints. Challenging negative automatic thoughts. People will not want to see me when I feel like that. It will not be fun to either challenge the negative thoughts in a formal way or to make behavioral experiments out of it. Recognize and decrease unhelpful activity, like oversleeping, especially a problem in chronic fatigue syndrome, that people stay in bed 12, 13, 14 hours. It's a very nice idea to do that one day, but the effect, if you probably have experienced it as well, if you sleep for 14 hours, actually it doesn't make you feel more alert. It makes you actually feel more tired. Medication overuse, eating patterns, social withdrawal, and so on. If we talk about dysfunctional ways to express and cope with strong emotion and impaired emotional processing, to increase the awareness of the patient about certain triggers, it's useful for the patient to keep a logbook and a timeline. By timeline, I mean to retrospectively say, at the times when my symptoms were the worst, what else was happening in my life? For example, when I first experienced this numbness on my left side, actually it was the time where my boyfriend had left me and I had to move house. When I had an especially bad time with my weakness in my legs, it was actually the time when also I had problems with my mother, or my mother fell ill. Yeah? So to become more aware that physical symptoms do not appear independent of other events. To identify responses at the time and increase helpful responses. Possible emotion regulation techniques are relaxation training, guided imagery, mindfulness, and meditation. For some people, especially if they are more typical of what in the past would have been called conversion disorder, dissociation can be present. Again, it will be important to really keep track of when does dissociation happen, what does it mean, what is it, and to maybe explain it in a sort of metaphor that it's a common reaction, it's not a pathological reaction that all of us can dissociate, for example, when we are very tired, when we take certain medications and so on, but that also it is not unavoidable. One useful metaphor might be a motorway or the German Autobahn, where even if you're on the Autobahn and you feel you're going only in one direction, you can always find an exit and can do something differently to leave that track and not end up at dissociation. Practice alternative behaviors, and that might be for dissociation, for example, physical activity, like when you feel that way, you can stand up, you can press your feet on the floor, you can speak, you can start to sing, to interrupt that cycle of dissociation, or direct your attention to experience the here and now. For example, I will focus my attention when I start dissociating on how the seat feels, or how the floor feels, or what I can hear at the moment. They're called grounding techniques. Interpersonal factors do play a role in the conceptualization, as we said. On the one hand, they can be a part of the current life stresses, part of the learning experiences, part of the dysfunctional ways to express and cope with strong emotions, and part of coping strategies and reactions we get from other people when we have somatic symptoms. So then the role becomes to discover the interpersonal relations that the patient has. What are they? Are they stresses or are they support? How do and did the illness beliefs and the reaction of others influence the patient's illness beliefs and coping strategies? The patient, if he has understood the model, Or in Wanda's case, she has understood the model and she says, I want to change and I want to do more activity. But if the mother she lives with says, oh, my child, don't do it, it will be dangerous for you, then you will have to talk to the mother as well. She has to understand the model as well, otherwise it will not work. And it might be useful to discuss with the patient how the patient, having learned about somatization, having learned about the alternative explanation, the patient thinks what could be useful as a response from, for example, my mother or my partner when I want reassurance. What should my partner actually say when I come and say, please tell me that's nothing bad in my body. Oh, I feel so bad again. There must be something bad. Let's go to another doctor. What response should the partner give? It might be worthwhile to discuss with the patient what might be useful. For example, the patient's partner could say, I understand you're in distress at the moment, but as we discussed with your doctor, actually as part of the therapy, it's more useful if we don't go to the doctor and if I don't give you reassurance. Yeah? So it should be agreed in front, maybe even written down, also by the patient, so that the patient can be reminded. We discussed that in therapy, giving reassurance will only reinforce the symptoms rather than make you feel better. It can be practicing of communication techniques and role play, behavioral experiments, challenging of negative automatic thoughts, and also explore the effects of withdrawal and effects of underusing or overusing help by others. Does it actually help if I constantly ask for reassurance, if I constantly want to be with other people? One issue that's also important to clarify is because people who have somatizing problems often have also, as we said, the systems are the same, there's rejection sensitivity, for example, when therapists change. And I'm not speaking necessarily of the psychotherapist, but if there's a physiotherapist involved or nurses involved and she changes, it can also often trigger an exacerbation of somatic symptoms, and somehow this has also to be clarified and worked on in therapy. Another point is that if the patient for years has told friends and family, oh, I've got a nerve damage, this is why I've got the symptoms, this is why I can't get out, this is why I can't work, then in therapy you have to discuss how can you now explain that in therapy you're getting better. You sort of have to devise a method to say, what can you say and to whom do you have to say it, that you're actually working on psychological factors. Do you have to explain it to everyone? If you get better, how can you save your face so that other people, or that you don't feel you have lied to other people? Yeah? As we're coming to the end, thinking once more of this conceptualization and talking about possible current life stresses, dysfunctional ways to express and cope with emotions and coping strategies, it's useful to practice this challenging of negative automatic thoughts and perspective taking, talk about core beliefs, practice problem solving, identify helpful versus unhelpful strategies, and the effect of avoidance, and enhance what commonly is called this internal locus of control. When I feel bad, when I feel depressed, when I feel anxious, there are certain things I can do to list the things that the patient can do. Who can I go for help? What can I do myself? What can I do first in terms of the techniques that we have used before I feel that I can't, that it's not under my control? And talking about possible traumatic experiences and comorbid psychiatric disorders, as we said, for some patients, for example, like Wanda, she had an abusive husband. And at some stage, therapy will have to talk about it, especially if it has developed for her into a post-traumatic stress disorder. Yeah? And then trauma-focused techniques, trauma-focused CBT in some selective cases, it might also be EMDR, can be applied to process that trauma. And if there's comorbid disorders like personality disorder, then spending more time on the core beliefs or on the schema level might be useful. Depression or severe anxiety disorders, usually I would say, because you're treating the patient with CBT, it can be treated within a CBT framework. In some selective cases, maybe you will add an antidepressant. Yeah. All right, so we've got 10 more minutes to go, which is good for time for questions. I hope I didn't fatigue you too much. I hope you didn't develop somatic symptoms while you were sitting listening. But if you have questions, please feel free to ask. Any questions at all? Be brave.